everyone, I'm your CEO, and we will begin with going over our agenda, which starts with the EMTAL Act, and continue on with our current issue of overcrowding, and finish up with our solution and conclusion. In April of 1986, Congress passed the Emergency Medical Treatment and Active Labor Act as part of the Consolidated Omnibus Reconciliation Act, or COBRA, in order to correct the issues regarding patient dumping. Patient dumping is the act of a medical center or hospital refusing to admit a very sick patient because of the medical center's fears that the medical bills will exceed the predetermined limit established to a third-party payer. Basically, the emergency rooms turn away patients based on whether they are insured or not. Overall, it was propagated to combat the discriminatory practice of some hospitals transferring, discharging, or refusing to treat innocent patients coming to the emergency department because of the high costs associated with diagnosing and treating these patients within the emergency department. According to AAEM.org, the Emergency Medical Treatment and Active Labor Act has three major requirements. First of all, the hospital must provide an appropriate medical screening exam to anyone coming to the emergency department seeking medical care. Secondly, for anyone that comes into the hospital and has a serious medical condition, the hospital must treat and stabilize the emergency medical condition. Thirdly, a hospital must not transfer an individual with a serious emergency medical condition that has not been stabilized unless several conditions are met, which may include the consent of the patient. According to Dietrich and Carpanzano, Americans made more than 115 million visits to the hospital's emergency room in 2003, and only 12% of those seen in the emergency room were admitted to the hospital. In addition, approximately 30% of hospital emergency rooms have been closed for over the last 2 decades. However, as the number of emergency rooms decreased, the number of emergency room visits has continued to increase by roughly 35%. The emergency departments represent the most important access path to the nation's healthcare delivery system because they are guaranteed to get access point for all of those who need care regardless of his or her ability to pay. The overcrowding occurs when the emergency department has more patients than bed capacity or is oversaturated. According to Dietrich and Carpanzano, the overcrowding results in many adverse contributions, including lack of quality care, prolonged wait times, which can be from hours to days, increased staff stress, breaches in confidentiality, which tend to transpire when patients are evaluated in non-traditional locations such as hallways or stretchers. This overcrowding creates a reoccurring endless cycle. An increase in emergency room patients results in prolonged wait times and increased staff stress, which results in less confidentiality and lack of quality care. Unfortunately, one of the major consequences of EMTALA has been its major role in becoming a major contributor to overcrowding. EMTALA requires that hospitals provide medical care and treatment regardless of a patient's ability to or inability to pay. Likewise, emergency rooms are unable to turn away any patient because of EMTALA regulations, no matter how minuscule a patient's needs are. That can include a minor cough or just the stomach flu. According to Dietrich and Carpanzano, more and more people are beginning to use the emergency department as a primary medical provider. Patients have become fully aware that visits to the emergency room are free, resulting in long waits, overworked staff, and poor quality care. Therefore, the creation and regulation of EMTALA has been a major cause of overcrowding within the emergency departments nationwide. As the CEO of Sacred Heart Hospital, I have noticed a great increase in overcrowding within our emergency department. This having many negative effects upon the well-being of our clients, staff, and our reputation. My job is to create a quality environment that supports the medical needs of our clients, as well as provide an outstanding work environment for our staff. This issue needs to be addressed immediately. Based on the problem of overcrowding in the emergency room, I propose that the emergency department become compartmentalized. With this, the emergency room would have several clinics within its department. This would truly involve more space and staffing. Overcrowding would be eliminated and the patient care would be highly effective. Upon entering the emergency room, the patient would go to the triage nurse as usual. However, once the patient meets with the triage nurse, he or she would be sent to different clinics within the department. Depending on the symptoms exhibited, the patient would receive the best care possibly in each clinic. For instance, children would go to a pediatric clinic, pregnancy to a labor and delivery clinic, urology to a urology clinic, severe lacerations to the surgical clinic, rashes to the skin clinic, possibly broken limbs would be sent to an orthopedic clinic. Fevers, flu, and symptoms would be sent to a flu clinic. Each clinic within the hospital would present itself like a family doctor's office and treat the patients for their symptoms. If more extensive hospitalization is necessary, the patient would be released from the clinic and sent to the general emergency room for a closer look at possible admittance. Having an emergency room designed with subunits would allow more patients to receive direct care in a timely fashion and with the direct quality patient care. Clinics within the emergency department would be cost effective as well. Many of the clinics could be led by physician assistants and nurse practitioners. The main emergency room would be run by medical doctors and specialty doctors. The emergency department design would need to be set up in an organized manner to eliminate confusion for patients and patient families. The new way to utilize an emergency room may appear confusing to the community at first, as they would not be adjusted to this type of service. Despite the initial confusion, this type of emergency care would be highly effective for all people and medical professionals. As with all emergency rooms, the clinic design would still service all people, as no person shall be denied care. Having the subunits within the emergency department would definitely create more opportunities for job security within the health field as well. However, keeping the clinics properly maintained and staffed appropriately may pose some challenges. The clinics would be open 24 hours a day, 7 days a week. Because of the vast amount of open services, the cost of maintenance, operations, supplies, and staffing definitely presents a major concern. In conclusion, the Emergency Medical Treatment and Active Labor Act is the practice of preventing discriminatory acts of the hospital transferring, discharging, or refusing to treat patients within the emergency room due to high costs. Unfortunately, EMTLA is a major contributor to the increase in emergency room overcrowding. Overcrowding within the emergency room entails that there are less available beds than the number of incoming patients, resulting in poor patient care, stressed out staff members, longer wait times, and breaches in confidentiality. Implementing a compartmentalized emergency department with specialized clinic is the best solution to fixing the overcrowding. As the CEO of Sacred Heart, it is my duty to ensure this problem is resolved in order to reach our goal in providing an outstanding environment for our patients and staff members. Thank you.